Another webinar from National Eye Center. I'll be presenting the principles of prescribing spectacles in children. As we know, children are young adults, but they have different needs or special considerations when prescribing spectacles, because they have other, it's not just refractive error, they have other special conditions. So as we go along, I'll be able to take you through what can guide in spectacles prescription in children. So this is a child who had cataract surgery. You can see he's wearing his phakic glasses, but if you have a close look, it looks a bit too big, because sometimes the availability of frames for these children, small faces, is not available. So you make do with what is available. So as an introduction, refractive error occurs when there is failure to focus light on the retina. And a child, who is a child? Is a person with age 0 to 16. This is the definition by WHO. And WHO has estimated globally 19 million children are visually impaired, and 12 million out of this 19 million have significant uncorrected refractive error. This was stated in the Community Eye Health Journal in 2015 when they talked about refractive errors globally. So what types of refractive errors do you notice in children? First of all, I need to define what amyotropization is, whereby a baby, a newborn, is born hypermetropic of about 2.5 diopters at birth. But as the eye develops, you know, the other refractive powers of the eye, that's the cornea, the axial lens, they all adjust to reach amyotropia, which is completed normally by the time the child is 6 years. But along the line, some can, because of some developmental problems, the eye can be hypermetropic. They can have a myopia, they can have astigmatism because of the corneal curvature, and then anisometropia, whereby there's unequal refractive error in the two eyes, whereby one is probably more than the other, but then hypermetropia is commoner with hypermetropia than myopia. So these are conditions that can also occur in children, and they need to be considered when given spectacles, so that you want complete compliance with the children and even with the parents. So this is just like a table showing the refractive status of a child from the first year of life, whereby as neonates, they have like +2. But if it's a premature, they're normally myopic, and then they become ametropic as the age increases. Some end up being hyperopic. Then astigmatism is so common in the first year of life, although it can be present of about 2 diopters. Then even anisometropia. Then by the time it gets to 3 to 5 years, the length of the globe increases, and you have the process of amyotropization in the first year, whereby the spherical refraction can be just about 1 to 2, which there's no need to probably correct. And then by adolescence, the eye is mostly ametropic by the time they're 6 years, but some can become more myopic than hyperopic. You could have a myopia, then you could have hyperopia, and then some are even hyperopic even at the age of 13 to 14. It depends on the condition, and maybe other factors, maybe family history, familiarity, like we know in myopia can be hereditary, and then maybe the other factors that come into play, that's also the cornea and the axial lens. Then, as we know, the eye increases in size with age, but reaches the normal by the time the child is has reached. So what are the objectives of pediatric refraction? Well, one thing is that the ophthalmologists and the optometrists that are doing pediatric refraction have to be very competent, because it's not easy to refract a child. We'll come to that to see the challenges. So you need to determine the refractive status in the infants, whether they are pre-verbal and whether they are verbal children. And you must provide important information on the refractive state of the eye. This is very important, especially when once you want to prescribe and you have to explain to the parents, because most times parents are not willing. There's that fear, there's that belief that glasses worsens the child's vision. So you need to give them an important information and tell them why that child at that age needs glasses. And then it has to be understandable, easily accessible. At this age, where you're expecting amyotropization, or you have to consider this prescription. If I give this child this prescription, will it improve his visual function? Will it be useful? And then will the level of refraction disrupt the normal visual development of functional vision? And then you have to think of the risk of amblyopia if you don't give this prescription. You know, the earlier you treat the refractive error, the better, because of the risk of amblyopia. Then also, it's not only for refractive errors. There are certain conditions whereby, what I mean, not refractive errors like hypermetropia, astigmatism, that the children need glasses, although those are the commonest we see. But children after cataract surgeries, whether they're aphakic or pseudophakic, they will need some form of prescription, especially if they're aphakic and it's bilateral. Those that have progressive myopia, and sometimes even spectacles can be used for protection, whereby to protect the eye maybe from trauma, maybe the child has lost vision in one eye, and then for certain conditions to prevent like glare, like in albinism and iridia, whereby the glare can affect the vision. And then in certain strabismus like intermittent exotropia, and then a condition whereby there is high accommodation convergence and accommodation ratio. We'll come to that. I'll explain it further. So what are the challenges that we face because it's really challenging. You can imagine trying to refract a child who is less than 5 years. Most of the times, from experience, we have to do it for those that are 3 years below. Sometimes you have to do it, or 2 years below, you have to do it under anesthesia. But if you can avoid it because of the risk of anesthesia to the child, you can quickly do a retinoscopy with the little cooperation. So most of the time, the children are uncooperative, and then the visual acuity is sometimes not reliable. But based on how children are, then refraction in children needs cyclopegia. This is whereby, because children accommodate at that age, so you need to use cyclopegia to break that accommodation so that you'll be able to get an end result. But you have to remember they have the risk of amblyopia if you don't prescribe. And then you need to be patient because you need to repeat, and you need to repeat the refraction, especially if you don't get the right endpoint and you think you're not getting the right thing. And then the prescription sometimes have to change depending on the age of the child, because like if the child is aphakic, you did cataract surgery for the child at the age of 6 months, you have to check that refraction every 3 to 6 months, so that you have to change the prescription. So sometimes the challenges is not just for you as the practitioner making sure that, but even for the parents that have to provide these spectacles, and so you need to probably counsel the parents very well, because sometimes most parents will tell you that this refraction, they're tired with a bit of changing glasses, or the child is also, and also the children are always breaking the glasses, misplacing it. So all these things are all challenges. And then sometimes availability of frames for the small faces are not readily available. These are all challenges that are faced. Then before you refract a child, you have to dispense spectacles. You have to check the visual acuity, and you have to use the one that is age appropriate. There's so many, I don't want to do it. One is for pre-verbal, verbal, and then the ones that are in preschool, which are readily available. National Eye Center will all have them for all the ages. The Cardiff charts, the Sheridan-Gardner, the Snellings for the older children, the picture chart, they're all available. Then you have to do a complete eye examination, examine the anterior segment, the posterior segment, just to know there's no pathology causing poor vision that needs other intervention apart from giving spectacles. Then extraocular motility must be checked. And then you have to do an orthoptic evaluation. This is necessary just to rule out if there's any squint that can, strabismus that can cause poor vision as well, or that needs refraction. Then the refraction, mainly for children, it's better to do cyclopegic, dry and cyclopegic. But in most cases, it's better to do the cyclopegic and using available cyclopegic agents such as atropine. And atropine is better to use the ointment because of the side effects. Then we have cyclopentolate, we have homatropine. These are the ones that are commonly used. But in our center, we commonly use atropine and cyclopentolate. And then the gold standard for refraction is retinoscopy. The retinoscopy, the strict retinoscopy, is still the gold standard for an objective refraction. Yes, the availability of autorefractors, but we know the problems with children getting them on the autorefraction. They might even be able to put their chin, their height might not be adequate. And then even the autorefraction can underestimate hypermetropia in some cases and overestimate myopia because it produces some form of convergence and there's producing some accommodation which can underestimate the hypermetropia and then overestimate the myopia if the child has myopia. So it's mainly advisable to do a retinoscopy. If the child cannot cooperate, especially those that are 3 years or 2 years below, I think it's advisable if one does an examination under anesthesia to do the refraction. Although there are some experienced optometrists that I've met during my training in Tanzania that are able to refract, do retinoscopy for children that are as young as 1 year, 2 years. So I think with experience, one will be able to just get something. So what are the principles of cyclopegic refraction? Since most children will need cyclopegic refraction. Well, when you do cyclopegic refraction is to determine the total refractive error during temporary paralysis of the ciliary muscles from using cyclopegic drugs, which I mentioned earlier. And this, which otherwise does not manifest on subjective non-cyclopegic refraction. And the total refraction, you're measuring the total hyperopia, whereby you have the latent, in hypermetropia, that could be hypermetropia due to accommodation problems, whereby there's total hyperopia, which could be latent, which is the latent one is the one that is measured when you do the cyclopegic refraction. Then you have the manifest, which is not due to the ciliary muscle tone, which could be absolute or facultative. The facultative is the one that the child overcomes with accommodation, and the absolute is the one that is not due to accommodation. So, indications for cyclopegic refraction, is it everybody? Well, ideally, all children should have, but more in young children, and then they are non-verbal and non-communicative. Young patients who have symptoms but not significant refractive error, latent hyperopia, those with strabismus, inconsistent endpoint refraction, those with accommodative astigmatism or esotropia, then patients with high heterophoria. Then if you have a poor reliability between the dry retinoscopy objective finding and the subjective finding, and you think that there is some problems there, then you might have to do cycloplegic so that you have an endpoint. Then those with pseudomyopia, whereby it's just a temporary, pseudomyopia means there's a temporary shift due to spasms of the ciliary muscles, which can increase the refractive power of the eye in some cases. So by doing cycloplegic refraction, you'll be able to abolish that. This is a table showing some selection of cycloplegic drugs, whereby we have atropine, homatropine, cyclopentolate, the age appropriate to use it. Although we can use the cyclopentolate in younger children, but you have to be wary of the side effects. Just last year, when we used a brand of cyclopentolate, we had some reactions in some of the children that were having cycloplegic reaction and mostly hallucinations. So you have to be wary of using it, especially in children that have some form of CNS problems. But atropine is better to use the ointment instead of the drops because of the side effects are less with the ointment. But you have to take into cognizance it lasts for about 2 weeks, and then the post-cycloplegic refraction will be like after 3 weeks of the first cycloplegic, when you did the retinoscopy with the cyclopegia. Then, but there's another one which is less harmful on shorter acting, which is homatropine, but it's not readily available. So we have atropine, cyclopentolate. Tropicamide is not all used all the time because it gives more of dilatation than the cyclopegia. And there's the tonus amount of refraction or diopteric power. When you use these drugs, you have to subtract. For atropine, is +1 diopters. For homatropine, is 0.5. Cyclopentolate is between 0.5 to 0.75. So what are the guidelines for prescription in hypermetropia? Well, this will depend on the age of the child, because as I told you, at the early onset of early years of the child, age of the child is normally hypermetropic. So that can, maybe when you refract a child and you see that it's an infant and the power you got is +2, you can probably just follow up to wait and see. Maybe some form of ametropization will take place and there's no need for the glasses. And then it depends on the amount of hyperopia as well. If it's lower than 2.5, some children can accommodate enough to overcome it, so no need for prescription. Then it depends also if there is astigmatism, that's symptoms, and then there's decreased near vision, because as we know, the child that is less than 3 years, his world is near him. They're not bothered about distant vision. That's why at that age, if they're myopic, or you can just follow up for some time to see, because they're not interested in distant vision. So prescribing glasses at that age in myopia might not be necessary. But near vision is very, very vital at that age in children. Then also, if there's presence of esotropia, if it's present, you need to give the full cycloplegic correction. There's the AAO, the American Academy of Ophthalmologists, developed a flow chart which can be used as a guideline for prescription of hypermetropia or all the other refractive errors. So for an infant, this is the flow chart. For an infant who is 0 to 1 years, if it is isometropic, that hyperopia, that means the two eyes have the same refractive error, and there is a deviation you do a cyclopegic refraction. But if the if the correction is you give the correction if it is more or equals to 2 diopters. But if it is less, you can just follow up, do a regular follow-up to find out if it's increasing. If there is no deviation and the error is more than like 5 diopters or equals to 5 diopters, you can start by giving just 2/3 of that and follow up the child as well. Then if there's anisometropia, there's no need if it's just less than 2.5. But if it's 2.5 diopters, you can give a partial prescription if there's no deviation. But if there's a deviation, it's better to give the full prescription. Then if the child is between 1 to 3 years with the same conditions, the flow chart, this is what you, the same thing you follow. And if it is less than 2, you have to follow up. If it is more than 3.5 or equals to 3.5, give the full prescription or you give or partial if there's deviation. Then if it is anisometropia, if it is less than 2, it's just recommended that you do a follow-up 3 to 6 months, every 3 to 6 months. But if it is more than 2, it's better to give the full prescription because of the risk of amblyopia at that age. And if there's no deviation, you can give a partial prescription, which will follow up and probably increase. But if there's exodeviation associated, the plus correction must be reduced. That means probably more of myopia than hyperopia. So in the preschool years, it's also the same thing. If there's deviation, you give the full cyclopegic correction, and regular follow-up is recommended as well. Then if there's no deviation, prescribe only when the error is more than 2.5 and the vision is affected as well. Then also in anisometropia, if it's less than 1.5, there's no need between these ages. But if it is more than 1.5, you can give the full prescription. If there's deviation, it's just the same with the other ages. Then at the school age, it's recommended we also do cyclopegic refraction if they're above 6 years, especially when you notice that the child is hyperopic. And we know that for school, we need good vision for both distance and near. So proper correction is always needed for them to do better. And well, normally by 6 years, we should expect the child to be emmetropic. But if the patient has emmetropia, it's better to prescribe accordingly. Because amblyopia is something that we need to be concerned with, especially in cases of high hyperopia, whereby they could have deviation and whereby there's esotropia and anisometropia. So we have to be wary of that and be careful. But if in the older child, that's older than 6 years, the error is the same in the 2 eyes and is more than 1.5 diopters, even without symptoms, it's good to give correction because they're in school, they need their near vision, they need to. Then anisometropia of more than 1 diopters needs full correction. So what are the guidelines for prescription in myopia? It also depends on the age. If the child is less than 3 years, as I told you, the vision of that child it's near him. That means the world is near to him, not looking into any distant object. So even if you give glasses at that time, the child might not use it, but it's too good to follow up because some might end up with high myopia. So it also depends on the degree of myopia, whereby you can have low, which is less than -2 diopters, moderate is 2 to 5, high is more than 5 diopters. And also presence of strabismus, especially intermittent exotropia. These are the guidelines also by the AAO for infants with myopia. If it's isometropic and they're between the age of 0 to 1 years, infants with low to moderate myopia may not need prescription because, as I said, they don't need to view things in fine details. So if it is less than 5, it's just for monitoring, constant monitoring. And then if it is more, you give the prescription, but you reduce by 1 to 2 because they might not be able to tolerate the minus 5 diopters at that age. And then if it's a toddler, it's just the same. But you prescribe when the myopia is high because some start school at the age of 3 years. And then if the child is highly myopic and the child needs, maybe a 2-year-old needs minus 15, maybe this could be due to other factors that are causing the myopia, the axial length, the other things, and he needs minus 15. It's better to start with minus before you want gradually so that the child can adapt to the use because minus 15 is a very high. And then you have to think of accommodation also. Then for preschool age 3 to 6 years, if it is less than 3, no need to prescribe, you constantly monitor, and if it's increasing, then you can prescribe. And also if it is more than 3, you prescribe, especially if there's no, and you reduce by 1 to 2 diopters if there's no deviation. For those that are in school age by 6 years, whereby they need their distant vision. So you need to give treatment for both distance and near. Although sometimes the emmetropization is completed by 6 years, but still there's the risk of deviation and amblyopia if it's present. So the full prescription must be given to abolish amblyopia, deviation, and avoid symptoms like squinting the eyes, whereby you see children trying to squeeze their eyes to make the image better. And then overcorrection should be avoided in myopia because it causes accommodative spasms leading to severe astenopia and also might lead to esotropia. So also if a child is myopic and he has iso deviation, it's better to give the minimum minus. And if the child has exotropia, the maximum minus is given for clear vision to induce accommodation so that to create accommodative convergence, which can control the exotropia, because in exotropia you have more of divergence. And then with the convergence, the child will be able to fuse. Then, as I said earlier, in very high myopia of more than minus 10, full correction can be barely tolerated. So under correction is recommended, but you can gradually increase it depending on the visual function of the child and the needs. So guidelines for astigmatism. Well, for astigmatism, accommodation cannot correct astigmatism. So cylindrical error of more than 1.5 to 2 can also be amblyogenic. And then the total cylindrical power should be given in young children because, especially those with reduced visual acuity, because sometimes they have symptoms and then children are able to tolerate cylinders more than adults. So especially if they start using it early, but one has to know that you have to do the centration. The person doing the optician or the person dispensing should be able to know how to do the lens centration, and the frame should fit very well. If not, there won't be compliance in using it, or will have problems. Some can also have oblique astigmatism, although it's rare after 12 months, but if it is there, it can cause amblyopia than the regular astigmatism, and then it needs to be corrected from 1 year, when the child is 1 year if it is present, and then 3/4 of the correction up to 2 years, and full correction after. If the oblique astigmatism is more than 1 diopters. This is another flow chart for showing how you can, the guideline for giving spectacles or for those with astigmatism, whether it's isometropic astigmatism and isometropic, the age of 0 to 1 year and the age of 1 to 3 years. You can follow this guideline for all the patients you're seeing. This is when the child is in preschool. If it is less than 1.5, no need to prescribe. If it is more than, and it can be given so that the child can adapt initially. Then if it is due to anisometropia and the child is above 4 years, there's no need to, if it's less than 1.5, there's no need to prescribe, you can monitor. Then if there's amblyopia, partial can be given after shifting to full, then after you can give the full treatment. Then if the child is 6 years, you need to give, if it is more than 0.75, you need to give the full prescription. If it is less, you can monitor, but if it's affecting the visual function of the child, you can, and the child has symptoms, you can still go and prescribe. If it's an isometropic astigmatism, if it is less than 1.5, follow up, no need to prescribe, but you follow up and you only give if the child is symptomatic. And then if it is more than 1.5, you need to give the full prescription. This is like a summary of the table of what I presented for the ages of 0 to 1 and ages 2 to 3 years by the AAO. You can see the table showing if those, if they're isometropic for myopia, and if they're hyperopic, if there's any deviation, if there's any esotropia, or if there's no esotropia, if the child has astigmatism and isometropia. So this is like a guideline. It might not really be a strict rule to be followed, but it's a guideline to what you can prescribe at this age group. And even if they have anisometropia, whether it's due to myopia, hyperopia, or astigmatism. So what are the guidelines for anisometropia? Well, as I said, hypermetropic anisotropia is more amblyogenic than myopia. And so prescription is necessary once it's established. Normally, you can have hypermetropic anisometropia when you have a difference of more than 1.5. If it's myopic, a difference of more than 3 diopters, astigmatism more than 1.5. But you need to note that anisometropia exceeding 3 diopters or sphere or 1.5 diopters cylinder makes spectacle use improper, because the difference the 2 eyes can tolerate, it shouldn't be more than 3 diopters. So it can cause confusion, can lead to the eye with the worst dioptric power being amblyopic. You can have suppression, and then they can develop strabismus. So when prescribing spectacles, one should take into cognizance that the difference between the 2 eyes, the refractive power of correction should not be more than that. So these are the stages, the dioptric powers of when there's a risk of amblyopia, whether in the anisometropic stage or isometropia. Then also, as I said, that some certain situations need spectacle correction, like bilateral cases of bilateral aphakia. If it is you can have cases of unilateral aphakia, which is more problematic in visual rehabilitation. We all know that. And the best for unilateral is to give contact lenses. But we also know the problems of sourcing contact lenses here in Nigeria, and then the other risks associated, and also even teaching the parents how to use it. So, but if it's bilateral aphakia, we know that they have the risk of amblyopia if you don't treat early, especially immediately after. It's advisable immediately after the surgery. In some centers, the child, as soon as the child has the surgery, glasses are prescribed to start using before the other eye is done. But if the other eye is done within 1 week of each other, they can start using the glasses immediately. They have a problem of high hyperopia. They have a problem of absence of accommodation because the lens is not there anymore. Then they could have astigmatism, although this reduces as they grow. And they also need refraction every 3 to 6 months because the eye is growing, the refractive state of the eye is changing, and you need to improve that vision so that they don't have the risk of amblyopia. For unilateral aphakia, you can use IOL, but if the child is not at the age that you insert IOL, it becomes problematic. So for those that have aphakia, if they're infants, that's less than 1 year, you try to overcorrect. You give them the single vision, you do their retinoscopy, get the power that they need, maybe +11, +10, and then you add what you think would be the near correction, which could be +2 or +3, and you make it as a single vision for the child to use at that time, because really they're not, they don't need to use bifocals before then. They might not be able to even use bifocals. Then as the child gets older, you can reduce the plus power, maybe gradually, because the eye is getting bigger, getting close to ametropization. And then it's advisable that by the time they're 2 years on their preschool, they should use bifocal, whereby the glasses should have a reading segment which the child for near vision, which is a must for any child that has that is aphakic, before probably planning to do a secondary IOL insertion, or you're going to leave that child aphakic. So they need to use bifocal. And the bifocal that is recommended is the executive type, which is not readily available now. It's expensive, maybe it's available. Then also those are pseudophakic, because sometimes we don't really get the right IOL power for these children. And we know that once the axial length from 0 is increasing rapidly, and after then it goes on gradually. So we don't always get the correct correction that we need for the IOL power. You find out there's some residual refractive error. So we need to correct that so that their distant vision can improve and they have a normal visual function. And then they too, pseudophakics, they need to have a near add, either depending on the age. If they're less than 3 years, you can give +2. If they're older than 3 years, you can give +3. And also, even pseudophakics, you need to constantly check their refractive error, because it might change. And especially if, depending on the power at ab initio that was used during the surgery. because some of them might end up becoming very myopic. So what are the disadvantages of spectacles and aphakia? We know just like in adults, there's poor cosmesis because of the thickness, and then we have decreased field of view, there's reduced retinal image, then they have lens aberrations. So what other conditions should you give bifocals? Well, as I mentioned, those that have bilateral aphakia, those that are pseudophakic in both eyes, those that have esotropia, constant esotropia, then accommodative esotropia, then high accommodative convergence accommodation ratio. I will explain on that further. So what other special situations should we give spectacles? Like those with intermittent exotropia, because in intermittent exotropia, we have loss of fusion when the eyes diverge. So you have to use concave lenses to induce convergence for them to have good fusion. So no matter the amount of myopia, it should be corrected using, and it should be less. Then any refractive error with reduced visual acuity and the presence of intermittent exotropia should be corrected to improve the vision fusion. Then if the child has intermittent exotropia, hypermetropia, and the VA is normal, there's no need to correct because there's no need, it reduces the urge to converge. But if it is due to high hypermetropia and there's decreased VA, you need to correct with the reduced power of the minus lens. Then another situation that needs spectacle treatment prescription is also a special situation is those with high ACA ratio. Normally, in such condition, the esotropia is near is more than that by the distance. Normally by more than 10 diopters. And then normally the normal ratio is 5:1. But if it is greater than that, then you have to do a cycloplegic refraction. And if the cycloplegic refraction is done and the distance deviation is corrected, but you still have deviation when it comes to near, one has to prescribe a bifocal so that it can take care of the near deviation. And normally it's advisable to give executive type of bifocals or the D-top. In such a situation, the reading segment has to bisect the pupil in such a way that, in the middle, in such a way that this is done so that the child is forced to use the near vision when there is need to use it. But the problem is that this executive spectacles are not available now. I don't think I've ever seen it. Maybe in pictures. Most of our opticians, when we tell them, they tell us that it's not available and it's expensive and it can't be developed. So we just do away with the normal focals and try to educate the children. This is where they need to use to read. But if the full distance correction does not reduce the distance deviation even after the cyclopegic refraction, and it's still more than 10 prism diopters, then surgery is for the esotropia is advised. Also, spectacles have been advocated for those with progressive myopia. There's this hypothesis that says some children with progressive myopia develop an accommodation lag with near object focus behind the retina. So you can use a progressive addition lens, which is the image on the retina to slow down myopia. This has not been, it's just like been tested. This that down. There are so many things that can have been advocated to slow down progressive myopia, like the use of atropine has also been advocated. So you can also use spectacles for protection. You have the tinted lenses, you have the photochromic lenses, the polycarbonate, or the ones for ultraviolet protection. But one has to know that the tinted and photochromic is not a routine for children, because once they're indoors, because of the light, they have a poor contrast. And contrast is part of our visual function, so it can affect the use. So it's not advisable to give children tinted or photochromic lenses unless in special conditions like those that have albinism, photophobia, and aniridia, and some form of colobomas, iris coloboma. You can also prescribe so that when they go outdoors, the glare is reduced. Then polycarbonate lenses are more ideal. It's shatterproof, that means it doesn't break easily, and can provide some form of ultraviolet rays protection, but it's also expensive. But it's readily available now, and it's even better than given the glass spectacles because of breakage. So some extra tips on spectacle prescription. As we know that visual acuity assessment is not so accurate, but maybe by the time they're 2.5 years, you can be able to get an accurate, something that is close to accurate. And then once you give them single optotype charts in children, those with amblyopia, because of the lack of crowding phenomena, you might miss them. You might miss. It's good to not to give them only the single optotype, so they'll be able to know whether the eye is amblyopic or not. And then, you need to prescribe based on the risk of amblyopia, and for that error, and then based on the age. Normally, it's said that 80% of children can cope with high power for the first time. If you give them glasses for the first time, 80% cope. But less than 20% might need reduction, especially if they don't comply to use it after 4 to 6 months. You can decide to reduce. Then you can hyperopes. You can give them some cycloplegic drugs in the first 2 weeks to relax the accommodation, so that they'll be able to tolerate high-powered lenses. It said that myopes respond easily to high powers than hyperopes. Then after the prescription, you need to review at 6 weeks or 8 weeks after to ensure compliance, to ensure that the glasses are being used, the visual acuity has probably improved. And then if there's amblyopia, you have to wait till, not immediately you prescribe glasses and you start amblyopia therapy. See that the child is using the glasses, because you're doing amblyopia therapy, the child is not using the glasses, then you're not winning. So even after considering the special situations of the conditions that need spectacles, you also have to consider the type of spectacles you're going to give the child. Because if you don't give the appropriate spectacles, then the child is not going to use it, and then the vision is not going to improve, and you're back to this square one, or even worse if there's amblyopia. So it's not just to correct the refractive error, you want them to have good binocular vision, especially those that have anomalies from binocular vision anomalies such as strabismus, myopia convergence problem. And then to look closely at the type of spectacles that is being given, because wrong fittings or choice of frames can result in discomfort, facial disfigurement, and costume compliance, as I mentioned. So when selecting a frame, one has to be sure that it fits correctly. It's not too big, it's not too tight. If it is too tight, the child will not use it. It is comfortable, it is durable, and also it does not affect, that means it does not sit on the bridge of the nose, very tight, affecting the development. It should be acceptable cosmetically, and I advise we give them, there are bright colors, colorful, don't give them the normal ones for adults. There are colorful ones for children that are available, and they are light, which can be tolerated. And then make sure that the pupils and lenses are correctly centered, because they don't want to give glasses whereby the child is not looking through it and the aim is being defeated. So in conclusion, the child eye undergoes dramatical and physiological development from infancy to childhood. So we need to take that into cognizance. And important to note that children are interested in their inner world at an early age. Don't bother about them looking at the distance. Most parents, when they come and they tell me that the child goes close to the TV at the age of 2 years or 3 years, I tell the parents that that's the best the child can see. When they tell me that it's going to affect the vision, I'll tell them no, it doesn't affect the vision. That is even making the child to see better, that gradually you see that the child is going to sit at the distance and watch the TV. But if you deprive him of the near vision now, it will be a problem. Then you need to give the appropriate refractive correction that is necessary for the child's optical and visual function. Then when prescribing, it's important to consider the age, because you're thinking of metropization and the visual requirements. You have to consider the visual acuity. Because why I said visual acuity, because it depends on if it's appropriate for that age and the distance that you tested that visual acuity. Then the presence of strabismus, and then amblyopia, and then the degree of error before prescribing the spectacles for the children. And cyclopegic refraction is the must for all, because it will be able to give you the full, especially in hypermetropia, the full correction that is needed. And then before giving spectacles, one has to do a cover test just to rule out strabismus before giving the prescription, because if you've missed it out, maybe the prescription you're giving might not work. Then finally, dispense spectacles that are appropriate and child-friendly for compliance. And then I need to add that when prescribing spectacles to children, you need to counsel the parent, because as I said earlier, not all parents children should wear glasses. They think it's going to affect their vision, especially at the early stage, especially those children we encounter going for cataract surgery. This child would need glasses, and you just find their countenance, they're not happy about it. They'll just do what they keep on saying is, I thought once you remove the cataract, they'll be able to see. And you have to try and counsel them and tell them the needs and tell them why it's very, very important that even after cataract surgery, the child will need glasses. Even if the child has a squint, the child will need glasses. Although for squint, some prefer glasses than the surgery, I think. So that should be very, very important too, because you want compliance. Most times you find out after prescribing, when they come back, they've not used the glasses. And also very important, when the child comes with the prescription you've prescribed and he comes with the glasses, it's advisable you look at the situation of those glasses, because most of the times, children, it's either it's scratched, it's either it's not sitting properly, it's either one side has gone like this or like that. So you have to be sure so that you're not achieving what you want to achieve. So it's very good to always tell them to come with their glasses. And if there's need to change the refraction, ideally, a child that is 1 to 3 years, you need to do constant check the refraction, because as I told you, the eye is growing. After 5 years, you can do it every 6 months. Once they are probably 8 years, you can do the refraction every 1 year. Once they reach adolescence, every 1 year as well. But those that have progressive myopia, it's advisable you do a thorough check to check for other complications, and then the rate at which they need to change their glasses. These are some of the references I looked up. So thank you very much for this, for giving me the opportunity to present in such a time where I hope everybody is safe. I hope very soon we'll all go back to our normal lives, seeing our patients out there. I'm sure some of them, well, I just hope nobody has amblyopia from refractive error that has not been corrected. Thank you very much. I would like to thank the people that have organized this, the management of National Eye Center, the residents. I'd like to thank everybody. Thank you very much.
We don't have any question yet, ma.
Okay.
Can you see the Q&A chat now?
Yes.
They are just sending thanks. Everybody's sending thanks. Okay.
What is the rationale behind adding +2 diopters of 3 is to for the near vision? You've removed the lens. The lens is part of what is involved in accommodation. So by removing the lens, you've reduced that. So this is to take care of the near vision. So, but when they are less than 1 year, you give them the total. That means if you were able to get, maybe you refracted and you got +11, then you add +2, making 13. So the child will be able to at least for the near vision, because at that age, less than 1 year, you're more interested in the near vision than the distant vision. And then at that age, the child cannot use bifocal. Please, for children more than 8 years with progressive myopia, is their refraction also going to be annual? Is their refraction also going to be annually or less? It should be. It depends on the amount of. For those that are progressive myopia, no, I think advisable we should do it every 6 months, because at that time, although by 6 years the eye reaches amyotropization, but depending on the progressive myopia, maybe the axial length is increasing. So I'll advise maybe every 6 months if it's possible. In situations where there is mixed error, e.g. myopic astigmatism, if there's myopic astigmatism, you apply the same principle of the myopia and astigmatism. You treat give the spherical power, and then the myopic, the astigmatic, you give also the astigmatic correction based on the visual acuity you get. Mm-hmm. Okay, thank you, Dr. Rilwan. He said that cyclopegic refraction with tropicamine is for aphakic, pseudophakic, and children who have undergone refraction and are using glasses already. Thank you very much for that information. So no more questions. Dr. Bature?
No more questions.
Okay. Thank you very much.
Thank you. Thank you so much.
Look forward to the next set of webinars that will be happening from National Center. Thank you very much.
Thank you.